topic which I am going to present in the ASCON Sunday, Calicut. So, regarding this topic, it's a not well studied or understood topic. So, a lot of controversies arises from each and every sentence of this presentation. So, the remnant preservation in ACL surgery, it's not a recent topic, but the studies are not adequate. So, the meaning is you don't wash out all the remnants that is seen when you do an arthroscopy for ACL surgery in order to get the proper anatomical landmark for your current case. So you can go for different types of reconstruction in ACL. For example, this is a patient, arthroscopic view of a patient with locked lateral meniscus, and the ACL injury is there, but the volume is almost preserved. And the femoral side, you can see a mid-substance injury, and there is a well-preserved fibrous extension. So what type of treatment you can offer depending upon this picture and having this theory in your mind. So it can be a partial ACL preservation. That was an ideal case for a partial ACL preservation because the volume is adequate and the femoral attachment is not complete but it's there. Or you can go for an augmentation. And this is a partial ACL preservation in which one bundle is preserved, the other bundle is given. Or you can, through that the remnant, whatever you can have a new ACL preserving all the remnants of the previous one, that is augmentation. So is it really new? Now it's almost not really reaching 2.5 decades since the description of ACLR with remnant preservation by Adachi et al. In 2000. And many studies have investigated the biological elements comprising the ACL remnant and their putative benefit if retained during ACL reconstruction. So just like the remnants of a great civilization which has a lot to say to the world, ACL remnants also has a lot to do. So what's the concept behind this? As it on, ACL remnant contains elements, example cells, blood vessels and mechanoreceptors, which are very essential to ACL function. It has been hypothesized that ACLR with remnant preservation may improve graft remodeling, which in turn more quickly and completely will restore ACL structure and function. This is the hypothesis behind this presentation or behind this concept. So the next problem is how and when will you decide whether you should go for augmentation or bundle conservation or the remnant preservation or whatever you want. So this is an important classification. It was published in 2005. It's Crane's classification in which there are 4 types. Actually, it was modified later by himself, but this is the initial classification which type 1 ACL is wrapped around the PCL. That is, it is detached from the femoral stem, but that is attached to the PCL. You might have seen during your scopy, the ACL is attached towards back to the PCL. And the type 2 ACL is observed to have healed to the roof of the notch, almost to the 12 o'clock position or 11 to 1 o'clock position. The attachment is there on the roof. And type 3 ACL, that is most important, that is appear to have healed to the lateral wall of the notch or the medial aspect of the lateral femoral condyle. That's the original ACL insertion, but not in the normal position because it is torn and it is reattached. And type 4, there is no identified ligament structure remained. So this is the type 1 ACL that is gone to the PCL, and type 2 to the roof top, and type 3 it's to the lateral wall, that is the most important, and type 4 there is no attachment or the. So this was again classified later into group 1 and group 2. That is the group 2 is the already stated classification. The 2A is attached to PCL, 2 to the roof, C, 2C to the lateral wall and 2D to the remnant. Whereas group 1 is only a partial rupture of ACL. This classification added whether the surgeon, this will allow the or the give light to the surgeon whether to go for a single bundle or a double bundle preservation, means reconstruction. The 1A is AM bundle is well preserved, anteromedial bundle, only the PL bundle is torn. Whereas 1B is the reverse. 1C, both AM and PL rupture, but ligamentous continuous fibers well preserved in the femoral attachment of ACL on femur. That is, I will come to that. There are two types of attachment of the ACL on the femur, the direct and indirect. And the indirect attachment will be there. Now, this is the 1A, 1B, 1C. 1A means AM bundle is preserved. 1B means PL bundle is preserved. C means both are torn, but there is a partial attachment. The two A, B, C, D we already mentioned. How the treatment goes. For 1A, 1B ACL remnants, the ruptured bundle, the isolated bundle reconstruction is recommended. And for 1C, 2A, 2B, 2C, single bundle or double bundle, we are doing the single bundle anatomical with the remnant preservation techniques. That was his inference. So the trained type 3 ACL remnants were shown to contribute to pre-op antero-posterior knee laxity. That is attached to the original, not original, towards the original ACL attachment. And although there were no significant differences among the groups with regard to clinical results, it's highly suggested that trained type 3 remnant should be preserved during ACL reconstruction. Now, what about the femoral site ACL remnant attachment? So this is another concept that was evolved later. A scoring system was given depending upon to which part of the femur the ACL remnants are there and the quality of the attachment. So there are, it's given as 5 categories. Each is given 3 points, means 0, 1 or 2. 3 groups. 0 means there is nothing. 2 means it's good, almost normal, and 1 in between. So the first one is a direct insertion integrity. The ACL has got a direct attachment of the femur and an indirect attachment of the femur. So the direct attachment is more posterior, indirect is a little bit anterior, and then the fibrous is again anterior to the indirect. So of the direct attachment, it's classified, divided. I don't know whether it was very anatomically divided. You can proximal, middle, and 3/3. If the 2 points were given, if more than 2/3 attachment remains. For example, if on the proximal portion it's more than 2/3 attachment, 2 points are given. In the middle portion, if there is attachment, if it is more than 2/3, again 2 points. And the distal third also, like that. If the point of attachment is less than 1/3, then 0 points. If it is between 1/3 to 2/3, it is 1 point. Okay. And then 4 is the fibrous extension integrity. That is the direct, indirect, and then the fibrous attachment. And if 2 points are given when a fan-like fibrous extension is present in more than half of the articular surface, and if it is less than half, 1 point, and 0 if no extension or no indirect attachment. And the 5th is the synovitis severity. So as you know, when the ACL is torn, it will be covered with synovium and then later by adipose tissue. And the ends will be, 2 points will be given when there is a yellow synovial tissue covered behind the remnant area, and 0 to severe synovitis as a finger-like proliferation. So when the synovitis is small, the points, that means that that's not a good remnant, so the score will be less. So this is the frontal view, and to know this scoring area on the femur, you have to go posterior to the remnant attachment. Actually you should go through the anteromedial portal using ideally a 70-degree scope, and you should see from behind. And this is probing indicates ACL injury, and this is the proximally it is good attachment, so you are given 2 points. Middle a little attachment, so 1 point. The distal part nothing. And the fibrous extension, that is only partially preserved, so 1 point. So this is the anatomy of the ACL on the femoral attachment, where you can have the indirect fibers, direct fibers, and then indirect fibers and the fibrous extension. So the score of remaining attachment on the femur area showed a positive correlation with the pre-op instability and meniscus status. Anterior laxity depends only on the proximal portion, that is the direct attachment of the proximal portion. And knee instability is correlated with status of direct insertion. And the medial and lateral meniscus injuries are correlated with the middle and distal part of the direct insertion respectively. And another point is, when you get a high score, that means that ACL remnant has to be preserved. Now the third concept is, what's the remnant volume? It is a proportion of the length of the remnant tissue of the injured ACL covering part of the reconstructed ACL to the total length of the reconstructed ACL. Total reconstructed length of ACL ന്റെ എത്ര ഭാഗം ഒറിജിനൽ ACL ഉണ്ട് എന്നുള്ളതാണ്. ഈ പടത്തിൽ നോക്കുകയാണെങ്കിൽ this is the full length and this is the proportion. ഇതാണ് കവർ ഇല്ലാത്ത ഭാഗം. And also the volume, the thickness also is considered. So here you can see it's of less than 1/3 volume. The original ACL more than 2/3 is destroyed or torn. So there is, the classification is no remnant, remnant of less than 1/3, remnant of 1/3 to 2/3, and remnant of more than 2/3. And this is a torn ACL with a small remnant, probably less than 1/3. And this is the normal fibrous extension, that is after the direct and indirect attachment, there are fibers that is attaching the direct and fibers to the articular, towards the articular margin of the femur. So the significance of this is when the volume is more, it gives better anterior stability, and it's more improved activity related clinical outcome, that is the side to side improvement. That means when after the ACL reconstruction, when a patient walks, if he is having better proprioception, the ground reaction force will be less. So naturally, further injury to the articular cartilage as well as the meniscus will be less. Again, all proposed advantages. So these are the advantages of ACL remnant preservation. One is accelerated graft revascularization and remodeling, then improved proprioception, decreased bone tunnel enlargement. That's because you get a tight seal when there are remnants in the tunnel mouth. So then actually the synovial tissue imbibition to the graft as well as to the tunnel is less. So naturally that's almost agreed by all the authors, the decreased bone tunnel enlargement. Then individualized anatomic bone tunnel placement, improved objective knee stability, that also is approved by most of them, and early mechanical support to the healing tissue with selective bundle reconstruction. All others, if you go to different meta-analysis, all will be different, the inference will be different. So the graft rupture rate after remnant preservation, 3 out of 2 says it's less, but 1 says it's equal. And the second look scopy, usually we get a thicker graft in case of remnant preservation was done, and it's a well vascularized and when synovialized graft. This yellow arrow shows thick synovial lining when compared to a ACL reconstructed without remnant. So is it graft specific? Which graft work better with remnant? Says the hamstrings. Why? I don't know. With allograft, only minimal. So the disadvantages proposed by the other group was only cyclops formation, then extension deficit, and then the arthrophyprosis and time less. But none of them were supported by literature. So what better remnant? Of course, these are agreed by all of them. Acute, if it is less than 3 months of injury, it gives more growth, means the remnant will be having more biological factors. And age, of course, less than 35, ideally 19 to 29. And what are the future perspectives regarding this? Future studies should better describe the ACL tear pattern, remnant volume, remnant quality, and surgical technique. Studies of long-term outcomes after ACLR with remnant preservation are needed. So my take home for you is preserve whatever you have if you are confident about the tunnel positioning, because you lose nothing. And the take home message, based on the present literature, there is promising but insufficient evidence to support the superiority of ACLR with remnant preservation over the standard technique. And it remains to be seen if and when remnant preservation should be applied in primary ACLR, and future research is needed to refine the indications and technique. Thank you.